me. Now I'd like to call Dr. Shruti Nishanth. She'll be speaking to us about traumatic pediatric cataract do's and don'ts. She is a poet who loves art, music, and good literature. She is a pediatric ophthalmologist at MNI Hospital, Chennai. Dr. Shruti.
Yeah, thank you so much. So today I'm going to be discussing about one aspect, which is the pediatric traumatic cataracts and how we deal with it. So traumatic cataracts in pediatric is like a double whammy, because you're dealing with a pediatric eye and as well as a trauma. Both are in ready to incite trouble for us. Can we play the video, please? Okay, so the concerns that we are looking at is the type of cataract. More often than not, these are total cataracts because of the injury, and some of them are blunt injuries, some of them are penetrating. The status of the posterior capsule, more often than not, cannot be assessed in these cases, so we need to do it intraoperatively. The timing of the surgery is again very important. I wouldn't recommend to go in and put in an IOL in the primary setting. We always do the repair and then we go plan for a secondary setting IOL after 6 to 8 weeks. So primary setting, only if ALC is breached, then we do a cataract clearance, but we still don't place the IOL in the first setting. The second stage, why we plan the IOL, is because of regular cornea, better IOL power calculation, there's lesser inflammation and better IOL centration. Now this was a 13-year-old kid who came in with injury with these blades that they play with, and you can see this cut straight through. This patient was first managed primary repair with a corneal tear suturing, and then followed by which the sutures were removed, and then the keratometry was found to be regular, and then only then the IOL power calculation was done. So this was almost 8 weeks after the initial injury was done and the sutures were removed. After suture removal, about a week or two is when we planned for the IOL power calculation and then go in for the placement of the IOL. So here you can see this nice big iris defect in the inferior aspect. And here I'm trying to see there's a PAS, there's a anterior attachment of the iris there, but I'm trying not to relieve it at the moment. So minimal removal of this kind of attachment of the iris is done. Handling has to be very gentle and very minimal. Again, you see the initial nick being done, and this is a Grishaber's intraocular rexus forceps. The holding is quite good with this and can be done through the side port. And here you can see, because it's a traumatic cataract, where the lens and the capsule may also be unpredictable to start off. So use adequate high whisk. Under high whisk, you can use this nice movement to centripetal movement to bring inwards, so that these pediatric cataracts tend to have extensions. So again, keep refilling viscoelastic wherever we feel that we are not getting the traction enough. And once we almost complete it, you can see the nice round rexus. The cataract removal per se is very easy, because we just need to do a irrigation the aspiration part. And this is placement of the IOL in the bag, because the bag was intact in this patient. Now what's important is to dial them with care, use a counter traction and then rotate them. Here I'm placing both the haptics on the side so that they don't interfere much with the lower portion, because you don't want to see a haptic in the visual axis, because there's an iris defect there. And then after placing the IOL is where we actually remove these adhesions and the extra things that we want to do. And here you can clearly see this thing. I know it's very tempting for the surgeon to kind of do an iris repair at this point, but believe me, in pediatric cataracts, less is more. So we manipulate as less as possible, and we'll be surprised at the way these children find these small areas where they can start seeing. This child actually saw 6/9. And that's a real good improvement, and they don't complain of this diplopia and other issues, because they have a very good neural plasticity. They tend to see well, and they kind of figure out where they want to see through. So no excessive iris repairs or all of that. We can save that for the postoperative secondary or tertiary procedures. Again, any traumatic cataract, please suture them, and the main wood has to be used 2 sutures, 10-0 nylon or 10-0 vicryl can be used. This patient was followed up with hourly steroids, because inflammation is expected, and the first week I follow them up every 2 days, because the first week is the most critical period where the inflammation comes back. Once you have a nice pupillary membrane formation there, then again the whole point is lost, the visual axis is gone and amblyopia sets in. So make sure the inflammation is subsided right from day 1. Plan for amblyopia therapy within 1 week of the surgery, so that the child does not go into amblyopia, and plan for EUA as well. This was another patient, again a 13-year-old guy with a history of a cracker injury, sudden loss of vision with pain and watering. The left eye had hand movements. Again, in this patient, we had to take, this was how the picture was, almost like a total subtotal hyphema with 3 mm, and you can see this dilated pupil, and we can't see much, but there is definitely a cataract. So this child was scheduled for AC wash in the primary setting, and after which we planned for the cataract procedure. And here you can again see that this vitreous echoes, low to moderate vitreous echoes in the vitreous cavity, and the retina appears to be on. So with this stage, we started the child on topical antibiotic because this was a blunt injury. This was not a penetrating injury. Here you can plan for a IOL in the primary setting itself. So once you take care of the inflammation and the glaucoma and all of that, and look for the intraocular pressures, the plan for this patient was lens aspiration with CTR because there was a little bit of phacodonosis with intraocular lens implantation and vitrectomy. Now in traumatic cataracts, I usually don't recommend to go for a posterior capsulotomy sometimes when there is a penetrating injury, because there is an onus of having introduced something foreign into the eye. So you can plan for a YAG later on because that's a little more sterile. But in some cases where the child is really young and they wouldn't cooperate for a YAG, it's always good to go ahead and do that. Make sure you inject some good antibiotic at the end of the surgery, intracameral antibiotic. So here again we watch out for a weak bag and vitreous prolapse. So that's something in our mind. And here again you see this child, blunt injury, so there's no penetrating injury here. Make a good two good side ports, and you can see these nice posterior synechiae, the synechiae that's developed there. Again, use the trypan blue to stain it. Gives a little more strength to the anterior lens capsule, so it isn't as elastic as it is without the stain. So I always stain them because it provides some strength to the capsule. Here again we tend to use a spatula to kind of gently release these adhesions, and while we release, just make sure and look at the way the eye is, the lens is moving, because that gives you a clue whether the bag is weak or not in that aspect. Again, you will not have any clue as to how the posterior capsule is at this point, so we need to take it really carefully. So gently release these adhesions, and these adhesions can be broad based, they can be over some distance, so make sure you sweep all the way through up to the angle. So make an initial nick again, and with the nick, because this was slightly older cataract, we can use an Utratas or a Rexis, Rexis itself to kind of start initiate it and then move it. We can use an Utratas or a Grishaber's intraocular Rexis forceps. You can see me starting off with the capsulorhexis needle itself, but as you go on, I see that I'm not having the good control. So I will immediately shift to the intraocular rhexis forceps here, because this is a very critical point where extension can happen. It's important to stay away from the area of the posterior synechiae, and that's important because that's probably where the extension happens or the tears happen. So again, very critical area here. Do it really slowly, and once you get the right traction at this point, you can just turn it, and then all the motion has to be centripetal, unlike in adult cataracts. So almost at the end of the capsulorhexis here, you can see it's coming in nicely, and that completes the capsulorhexis. So once the capsulorhexis is done, then it's lens aspiration is very simple. We try to kind of release it just using irrigation, but then we need to bring in the irrigation aspiration as well. So here you can see the irrigation aspiration. So removal of the cataract is very easy in pediatric cataracts. The only thing is, as you are aspirating, just keep an eye on the PC, because we don't know the status of the PC. So just keep an eye on how the PC is at that point. And something that I've not done here, but I would recommend, is to keep the irrigation probe towards the angle and towards the side, so that you're not directly irrigating the vitreous if it is exposed. So here again, we're removing the cortex, and once that is done, we do realize that there is no PC defect at this point, so that's a safe thing. Again, here I would not endeavor to do a direct posterior rhexis in the first setting. So what we plan to do is to place a CTR to provide the adequate support, because somehow we felt that the other side did not have the support. So we can see the CTR being placed. So once the CTR is placed and the bag has adequate support, then we go in with the IOL placement. So again, in pediatric cataracts, we tend to use hydrophobic acrylic single piece IOL in the bag placement. So here I wanted to place we wanted to place a three piece IOL, so that it provides a little better support. So just gently nudging it in, and placing the haptics at the area of the deficiency provides a little better support. So that's what's being attempted here. So just gently nudging in the IOL, and the IOL is quite centered. At this point, we take a call to do the vitrectomy, because somehow the posterior capsule was not very clear. So again, a troca was placed, and we plan to do a vitrector rhexis from the posterior, from the pars plana approach. So the irrigation probe can be placed in the anterior segment itself, and just you can see a clear, nice vitrectorectosis being performed in the from the posterior aspect from the pars plana approach. And once we make a nice clear opening, we are pretty sure that the visual axis is clear, and that's very important. We can make a nice big one because we know that at this point the iris is also going to be slightly dilated because of the trauma. So removal of some of the peripheral debris as well. And once that's done, again we need to suture the ports, and that's very important in traumatic cataracts, to suture the ports and make sure all the ports are wound airtight. Because they do not have very good scleral rigidity, so it's important to suture them, all pediatric cataracts who have undergone trauma. So once the trocar is removed, so this is the post-op day 1 and day 10. You can see how well the central the IOL is, and the child had a good vision of 6, 9 and N10. Thank you.
Thank you, Dr. Shruti. As a VR surgeon, I've got only one question. How often would you do an SFIOL, and do you have an age cutoff where you would say no SFIOLs below this age, or for that matter even iris color lenses?
Well, I would think that around 8 years is when the child kind of goes into this kind of complete development, and anything beyond 8 years I would definitely recommend an SFIOL if there's no good back support. But lesser than that, there is a higher chance of displacement, or this higher chance of extrusions. So I would probably reserve it up to maybe around 8 years and above.
Iris color lens also same?
Yes, similar. And of course there should be no systemic contraindications and collagen based deficiencies.
Thank you, Dr. Shruti.